Have your work take center stage when you submit your cutting edge abstract for RSNA 2025. We're accepting abstracts on enhancing diagnostic impact from routine imaging, radiologist and industry collaboration on integration of new technologies, advances in low and non contrast techniques, imaging guided oncologic therapy from histotripsy to theranostics, and high impact clinical trials in radiology. Submit your abstracts by August 6th. Learn more at rsna.org/abstracts.
Hello, my name is Moassefi from the Mayo Clinic. Welcome to the RSNA Radiographics podcast. I will be talking about the article A Spectrum of Cognitive Biases in Diagnostic Radiology by Dr. Si-Young Yoon and her team. Cognitive biases are mental shortcuts, often unconscious, that help us process information quickly, but in radiology, they can lead to diagnostic errors. With increasing imaging volumes, limited clinical data, and time pressure that all of us are feeling, especially in the emergency radiology, understanding these biases becomes critical for patient safety. We can overcome these biases only by learning about them and developing awareness of their impact. This article is unique in its approach. It categorizes biases by the stages of interpretation that a radiologist goes through. Many of these biases can overlap and occur across these different stages that I'm talking about. Now, I'll guide you through the different stages of image interpretation, highlighting a number of cognitive biases at each stage. For a deeper dive into all different biases that are discussed in this paper, I highly encourage reading the full article. The first stage that we want to talk about is biases related to patient and order characteristics. Before the images are even opened, we are already vulnerable to multiple biases. The first one is framing bias. The way the clinical question is presented can shape our interpretation. For example, the phrase worst headache of life may prime us to look only for a subarachnoid hemorrhage, missing other possibilities like, for example, subtle infectious sign in the image. The second bias that I want to talk about is attribution bias. Imaging findings are attributed to the provided and available patient information, in particular the patient characteristics and demographic features and the resulting stereotypes that come to our mind with that. Suspecting an enhancing lesion in the spinal canal to be an epidural abscess rather than the neoplasm because of the patient's reported history of intravenous drug abuse is one example of this attribution bias. The third bias that I want to talk to you about is triage queuing. This means that, for example, if a case is marked as code trauma versus back pain, our suspicion for acute pathology automatically shifts. The other one is context bias. And also the other one that is similar to context bias is gambler's fallacy, which are both biases that are caused by recent cases that influenced a radiologist's current experience. For example, doubting a third consecutive positive pulmonary embolism scan. The last one that I want to explain in this stage is contrast effect, when a severe finding in one patient's imaging causes us to downplay subtler findings in the same or the next patient that we are seeing. The ways for mitigating these biases for this stage are first, try reviewing images before reading the clinical indications. And the second one is return to clinical context afterwards for final synthesis. And the last one is be mindful of subconscious influences from previous cases or stereotypes that we know about. The second stage that this paper is talking about is biases in image review. This is the hands-on phase, and still we are not safe. The first bias for this stage that the paper is talking about is a scout neglect bias. A scout neglect bias has been described as one's tendency to neglect to review all available scout images, particularly when the higher yield images have already been reviewed. Similarly, this could apply to the neglect of selecting windows and imaging series due to their lower perceived yield that we have in mind. For example, a non-displaced calvarial fracture that is appreciable and only the sagittal reformation of an otherwise normal appearing axial head CT could be overlooked during the interpretation of a, for example, polytrauma CT study. The second bias that we want to talk about this stage is blind spot bias. The classical example of that is the study that showed radiologists are missing a gorilla image in the lung CT that was inserted in the lung CT, and it means that we only see what we expect to see, not what is actually there. This is the blind spot bias. The third one that is talked about for this stage is satisfaction of search, which means that finding one abnormality and stopping the search, potentially missing the second one, which might be even a more critical finding for the radiologist to figure out in that image. The debiasing tools for this stage are: first, use personal checklists or search patterns. Build habits around reviewing scout images and alternative windows. And the last one is peer learning programs can help uncover personal blind spots. The third stage that this paper is talking about is biases in processing findings. This is where a memory and experience start to change our interpretation. The first one is familiarity principle, favoring diagnoses that we are comfortable with, even if they're statistically less likely. And the other thing that is similar to that is ambiguity effect, avoiding unfamiliar or complex diagnoses, the ones that the radiologist is uncomfortable with. The second bias that we have for this stage is anchoring and confirmation bias, which means that we stick to our first impression, then seeking only information to support that while we're ignoring contradictory evidences. The practical tips for overcoming these biases, the first one is consciously consider alternative diagnosis. Even if you're confident, always ask yourself, what else could this be? And the second one is collaborate with other radiologists. Second reads can dilute these anchoring effects that we might have. The number 4 stage that the paper is talking about is biases in the study dictation. Even in reporting, we are not free from bias. The first bias that is introduced for this stage is bandwagon effect or diagnosis momentum, which means that going along with the consensus with clinicians, even if imaging is not supporting it. The second bias is satisfaction of report and alliterative bias, which means that we want to echo prior reads without critical reevaluation of that. The third one is blind obedience, which means that we are over-deferring to a senior radiologist or AI system. And the last one is automation bias, which means that we are relying too heavily on AI or PACS measurements, even when your eyes is telling you that something is not okay, something is not really working here. The strategies for overcoming these biases for this stage. The first one is that it's good to form your impression first before reviewing prior reports or knowing other radiologists or clinicians' impression or AI prediction, all of them. It's good to have the first impression in your mind and then going to those. And the second one is trust, but verify prior reports. The stage number 5, or the last stage that this study is talking about in image interpretation, is biases after sign-off. The first one is feedback sanction or time delay trap. Lack of outcome follow-up means we cannot learn from our errors, and we may learn from the errors when it's very, very late. The second bias is hindsight bias, looking back and saying this should have been very obvious and losing confidence over it, even though this finding was not obvious at the time that the radiologist was reading the image. For overcoming this stage bias, there are ways that the paper is presenting. The first one is flag equivocal cases for follow-up. The second one is use morbidity and mortality conferences as learning points, not just blaming opportunities. And the last one is develop departmental database to track patterns and errors that radiologists make over time. In conclusion, cognitive biases are universal. They're not signs of weakness or incompetence, but of being human. The key is to acknowledge their presence and take active steps to reduce their impact. Think of this process as meta-imaging, imaging how we think, implementing personal search patterns, using peer feedback loops, and creating culture of learning can help us all evolve from biases to balanced interpretations. Thank you so much for listening.